Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Semua dah cukup ke?
Lagi 2 orang.
Okey, once cukup baik tu kan?
Okay.
Okey. Assalamualaikum, tak ada lagi ke? Tak cukup lagi?
Masih menunggu.
Macam mana? Tak cukup lagi?
Belum lagi. Okey, lagi seorang je.
Okay.
Okay, Doktor, dah cukup.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Kita mula dengan umur kita apa tu? Oh, saya di dalam tadi. Kau mana? Pusing. Pintu besar di dalam sana. Okey dah, boleh start.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Today we will be presenting about endocrinology. So these are the topics that we will be presenting today. Starting with childhood diabetes mellitus that will be presented by me, Faraanis binti Ahmad. So this is roughly the outline of my presentation, starting from definition to briefly about the management of diabetes mellitus. Okay, diabetes mellitus is a common chronic metabolic disease that is characterized by hyperglycemia as a cardinal biochemical feature, and it involves abnormality in glucose regulation, whereby the body does not produce enough insulin or fails to respond normally to the insulin produced because of insulin resistance. Next, before we discuss any further, let's take a look at the physiological basis of two important hormones, which are the insulin and glucagon. And both of these hormones is produced by clusters of cells in the pancreas, which is the islet of Langerhans. Insulin is secreted by beta cells, and its function is to reduce blood glucose levels, while glucagon is secreted by alpha cells. And glucagon is used to increase our blood glucose level. Okay, next, insulin will reduce. This is basically the physiology of insulin. Insulin will reduce the amount of glucose in the blood, starting with the binding of the insulin to insulin receptors that is embedded in the cell membrane of insulin responsive tissues, such as muscle cells and also adipose tissue. And when activated, these insulin receptors will cause vesicles containing glucose transporter that are inside the cell to fuse with the cell membrane. And this allows the glucose to be transported into the cell. And while glucagon does exactly the opposite of the insulin, glucagon raises the blood glucose level by getting the liver to generate new molecule of glucose from other molecules. And also glucagon will this is the physiology of glucagon will generate new molecules of glucose from other molecules, and it will break down glycogen to produce glucose, and then the glucose will go to the blood and eventually will lead to increase in blood glucose level. So the main classification for diabetes mellitus are these four. The first one is type 1 diabetes mellitus. The second one is type 2 diabetes mellitus and other specific types, and also gestational diabetes. And today I'll be focusing more on type 1 and type 2 diabetes mellitus that affect children and adolescents. For type 1 diabetes mellitus, formerly known as insulin-dependent or juvenile diabetes, that is caused by autoimmune destruction of beta cell in the islet of Langerhans of the pancreas that produces the insulin, and destruction of the beta cell will lead to permanent or absolute insulin deficiency. As for type 2 diabetes mellitus, it is formerly known as insulin-independent or adult onset diabetes mellitus, and it results from insulin resistance and relative insulin deficiency, and it is caused by various factors. And among these two types of diabetes mellitus, type 1 diabetes mellitus is the most common type of diabetes mellitus in children and adolescents. However, incidence of type 2 diabetes mellitus is nowadays in rising trend among young people, especially children and adolescents, and this can be due to obesity. Next, about the pathophysiology of type 1 diabetes mellitus. It starts with genetic susceptibility, for example, if there is mutation in the human mucosal antigen, and also environmental factors such as diet, like, for example, milk feeding at early age, viral infection, such as Coxsackie virus, cytomegalovirus, mumps, and also rubella, and also drugs and stress. And these factors will then lead to breakdown of immune system self-tolerance of pancreatic beta cells. Our self-tolerance protect us from autoantibodies that attacks against our self-antigen. So loss of this will lead to autoantibodies that produce against our self-antigen, and what for this case, autoantibodies will be produced against the beta cells, whereby our own T cells will attack beta cells at the pancreas, and this will result in loss of beta cells mass, and the beta cell mass can be lost up to more than half, and then it will result in reduction in functional beta cells, whereby it can be less than 10% of beta cells that are still functional. Then it will lead to insulin deficiency. The remaining beta cells that are functional are insufficient to maintain normal glucose level, and this will lead to hyperglycemia in type 1 diabetes mellitus. Basically, this is how type 1 diabetes mellitus occur. Next, we move to the complication of type 1 diabetes mellitus. So the common complication of type 1 diabetes mellitus is diabetic ketoacidosis. Okay, the first one is, this is how diabetic ketoacidosis occur. The first one is hepatic oxidation of fatty acids that will lead to production of ketone bodies, and eventually it will lead to metabolic acidosis. The next one is severe dehydration in diabetic patients also result in decreased tissue perfusion. So there will be reduction in oxygen that goes to the cell, and it will result in production of lactic acid, and this also will worsen the acidosis. And then the next one is hyperglycemic state in diabetic patient will induce the osmotic diuresis leading to dehydration. And also because of the acidosis, vomiting can occur, and vomiting will worsen the dehydration because of the fluid and electrolyte loss. Also, the loss of electrolytes in urine and transmembrane alterations because of the acidosis will lead to electrolyte abnormalities. Okay, the next one is also because of the acidosis, there will be increase in hydrogen ion because of the acidosis, and then it will result in accumulation of the hydrogen ion, and the hydrogen ion will exchange with potassium, so that potassium move from the cells to the blood, results in hyperkalemia. And as I mentioned before, there will be increase in hydrogen ion in acidosis. So our body need to eliminate the excess hydrogen. And in order to eliminate this hydrogen, phosphate is required. So as a result in elimination of the hydrogen ion, phosphate will be eliminated along with the hydrogen. So this will lead to depletion in phosphate. And the last one is sodium will also be reduced as a result of osmotic diuresis and also vomiting. So basically, this is the summary of what I've explained. The first one, it leads to acidosis, and then this acidosis will then lead to dehydration and also electrolyte imbalance. As for electrolyte imbalance, hydrogen will be increased, and potassium initially it will be increased, and later if there is a severe potassium depletion even in the cell, so later the potassium level will be reduced. But reduced in potassium in blood indicates that there is severe depletion of potassium in the body. And then the next one is phosphate. Phosphate will be increased and sodium will be reduced. Okay, the next one is we'll move to the pathophysiology of type 2 diabetes mellitus. It is actually not well known, but there are few risk factors that is predisposed to type 2 diabetes mellitus. The first one is obesity. And then the next one is low physical activity and excessive calorie intake. As low physical activity and excessive calorie intake can lead to obesity. And strong family history of diabetes mellitus, also a risk factor, and other metabolic syndromes such as hypertension, dyslipidemia, or polycystic ovarian syndrome, especially in teenage girls. This can lead to type 2 diabetes mellitus. And then these risk factors will lead to peripheral insulin resistance. And when our body has peripheral insulin resistance, our body try to compensate that. So to compensate that, there will be increase in insulin secretion. So that is the compensatory hyperinsulinemia, and eventually there will be failure by the pancreas to maintain the adequate insulin secretion, and this will lead to hyperglycemia in type 2 diabetes mellitus. Okay, then we move to the complication of type 2 diabetes mellitus. Okay, in type 2 diabetes mellitus, the patient is insulin deficient, and our body try to compensate that. There will be counter-regulatory hormones. So insulin deficiency will lead in reduction in glucose utilization, and there will be also gluconeogenesis from lipolysis and proteolysis. And glucagon will also add to change glycogen to glucose, so this will lead to glycogenolysis. So these three factors, glucose utilization, gluconeogenesis, and also glycogenolysis, will lead to the hyperglycemia state in the body. So hyperglycemia will eventually lead to glycosuria, and because of this glycosuria, the osmotic diuresis lead to loss of water and electrolytes, and this will lead to dehydration. And if the patient is already dehydrated and then there are decreased fluid intake, it will lead to hyperosmolarity state. And also dehydration can lead to impaired renal function. So this state is called as hyperosmolar hyperglycemic state, HHS, that is formerly known as non-ketotic hyperosmolar syndrome, or also known as hyperglycemic hyperosmolar non-ketotic coma. This is a complication of type 2 diabetes mellitus, and it actually has higher mortality rate as compared to diabetic ketoacidosis. And it is usually developed after a period of symptomatic hyperglycemia, in which fluid intake is inadequate to prevent extreme dehydration due to the hyperglycemia-induced osmotic diuresis. And there are few triggering factors or precipitating factors that can induce this state, which are acute infections or other comorbidities, intake of drugs that can impair glucose tolerance, such as glucocorticoid, or intake of drugs that can increase fluid loss, such as diuretics, and also if the patient is non-adherent to the diabetic treatment. And it is characterized by severe hyperglycemia, extreme dehydration, hyperosmolar plasma, and also altered consciousness. So basically in this HHS, there is no acidosis and absence of ketone like in diabetic ketoacidosis. The serum of ketones are not present because the amount of insulin that present in most type 2 diabetic patients are adequate to suppress the ketogenesis. And because the symptoms of acidosis are not present, most patients with this state, HHS, can endure this for a longer period of time. So when they present, the plasma glucose and also osmolality are much higher as compared to diabetic ketoacidosis. So their condition is actually worse. So this explains why HHS has higher mortality rate as compared to DKA. Next, okay, this is the differences between type 1 and type 2 diabetes mellitus. The first one is the age of onset for type 1 diabetes mellitus from 6 months to young adulthood, while type 2 diabetes mellitus usually after pubertal or later. As for clinical presentation for type 1, usually it is acute, rapid, while type 2, usually the symptoms is insidious. As for autoimmunity, it is present in type 1 diabetes mellitus, and there is no autoimmunity in type 2. As for ketosis, it is common in type 1 diabetes mellitus as compared to type 2, which is rare. As for body habitus or body build, usually patients with type 1 diabetes mellitus, they are lean, but they can also be overweight. As for type 2 diabetes mellitus, we know that obese is one of the risk factors. So usually patients with type 2 diabetes mellitus are overweight or obese. As for endogenous insulin in type 1 diabetes mellitus, as we know that they cannot produce insulin, or there is very little insulin that is produced. So there is low or absent insulin, endogenous insulin. While in type 2, the level of insulin can be decreased, normal, or also increased. As for the next one is acanthosis nigricans. This is the clinical manifestation that is usually absent in type 1 diabetes mellitus, but commonly present in type 2 diabetes mellitus. Acanthosis nigricans is actually a dermatologic manifestation of hyperinsulinism or insulin resistance when the patient present with hyperkeratotic pigmentation of the nape of the neck and also flexural areas such as armpit, elbows, or groins. Okay, the next one is clinical manifestation, further classified as early or late clinical manifestation. As for early clinical manifestation, the most common presentation is these three classical triad, which are polydipsia, excessive drinking, polyuria, and also weight loss. And the less common one is anuresis, which is the involuntary urination, or patient can complain with bad wetting, skin sepsis, or infections. Patient can present with recurrent infections. And as for late presentation, specifically in diabetic ketoacidosis, patient can present with nausea and vomiting, abdominal pain that can mimic acute abdomen, dehydration, rapid breathing, which is the small breathing, smell of acetone in their breath, which is the fruity odor of their breath, altered mental status, which is disorientation to coma, hypovolemic shock, and also drowsiness. As for diagnosis, to diagnose a patient with children with diabetes mellitus, it should be made on clinical features and also biochemical criteria. And if the patient, we can diagnose them to have diabetes mellitus if patient present with classic symptoms of diabetes or hyperglycemic crisis with random blood glucose of more or equal to 11.1 millimole per liter, or fasting blood glucose more than 7, or oral glucose tolerance test more or equal to 11.1, and also HbA1c or glycosylated hemoglobin that is more than 6.5%. But if the patient, if the glycosylated hemoglobin is less than 6.5, we cannot exclude diabetes mellitus yet. Usually, random blood glucose and fasting blood glucose is enough for us to diagnose diabetes mellitus. And OGTT and HbA1c may be performed if required. If required. And for autoantibodies testing, this is specifically to diagnose type 1 diabetes mellitus. So we can do these tests, which are the glutamic acid decarboxylase antibodies, anti-islet antibody, insulin autoantibodies, and also protein tyrosine phosphatase antibody. And for fasting C-peptide, we can also do C-peptide test. So C-peptide is the byproduct that is produced along with insulin in the beta cells. So it can differentiate between type 1 and type 2 diabetes mellitus, whereby C-peptide levels are suppressed in type 1 diabetes mellitus, as we know that patients with type 1 diabetes mellitus cannot produce insulin. Okay, these are the long-term complications of diabetes mellitus, further classified as microvascular and also macrovascular. For microvascular, it is retinopathy. The complication is retinopathy and nephropathy. And as for macrovascular, coronary artery disease, cerebrovascular disease, peripheral vascular disease, peripheral and autonomic neuropathies, and also diabetic osteopathy, whereby patients are present with osteoporosis and fracture because they are at increased risk of osteoporosis and fracture. Okay, the next one is in management. I'll be explaining briefly about the management. As our treatment goals are to normalize the patient's blood glucose level and also to prevent or delay the onset of complications. So for type 1 diabetes mellitus, as we know that they cannot produce insulin themselves, so we need to give them insulin and they need to self-monitor their blood glucose level, and also we can advise them to change their diet to a more healthy diet, and we can advise them to eat regularly in a consistent amount, limit intake of carbs and fats, and also increase in physical activity. And the next one is for type 2 diabetes mellitus actually. And as for type 2 diabetes mellitus, we can advise them to, first is we can advise them to change their diet to a more healthy diet. For example, we can advise them to eliminate sugar containing drinks, avoid skipping meals and eat regularly, and also control their portion size, eat low fat diet. And also we can advise them to lose weight, as lose weight can increase insulin sensitivity. And if we need to give them medication, we can start with night insulin medication such as metformin. And insulin is given if they require insulin. So I think that's all for me.
Okay, that's quite an extensive one. Anyone got any questions? Can you go through the first few slides? Your first slides. The first one. Okay, okay, go to your fourth slide. Third or fourth. Okay, that one. That one. The next one. Next one. Next one. Okay. Okay, any questions? Any question to the presenter? Diabetes is quite important, because it's not that uncommon among the endocrine. Of course, hypothyroid is the most common, congenital hypothyroid in pediatric, but diabetes is not that uncommon. All center or all hospital memang akan ada DM lah, especially DM type 1. And in our center we've got, I think, 3 patients with DM type 1. So any questions? Okay, tak ada. Okay, then boleh tu lah. The topic kan, where do you get the topic ah? Who gave you the topic, the disease?
From the department.
Yeah. I think the previous team, the previous group, I told them to skip the Cushing syndrome, which I think is not important in pediatric. It's not that common. But okay lah, since you prepared. Tapi try to make it short lah. You don't have to read the whole slides. At most 15 minutes per presentation, and then the rest we just, after you present briefly, then we go through each slides, and then you can ask questions lah. Okay. So make it 15 minutes. Okay, boleh proceed. Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Muhammad Akil Akram, and as second presenter, I will present about Cushing syndrome. Next. This is my outline for today's presentation. Next. Cushing syndrome is a condition when blood level of cortisol or other glucocorticoid is abnormally high. It is a rare condition in childhood. Next. Overall incidence of Cushing syndrome in all age group is approximately 2 to 5 cases per million people per year. Only approximately 10% of the cases each year occur in children. Next. As Cushing syndrome is mainly caused by cortisol, a glucocorticoid hormone, we should know how this hormone is produced. Corticotrophin releasing hormone is synthesized by paraventricular nuclei in the hypothalamus and carried to the anterior pituitary in the hypophyseal portal system. CRH stimulate ACTH released from anterior pituitary, which in turn stimulate adrenal cortex, specifically zona fasciculata, to secrete cortisol. And then cortisol inhibit the secretion of primarily CRH and secondarily ACTH in a negative feedback regulation system. Next. We should know the effect of cortisol to our body, as we can predict what will happen in patient with excess glucocorticoid. Cortisol play a major role in glucose, protein, and lipid metabolism. It stimulates the synthesis of glucose from non-carbohydrate sources, resulting in increased level of glucose in blood. Cortisol also promotes the breakdown of protein, which can result in muscle wasting in chronic state of cortisol elevation. And initial surge in cortisol level trigger lipolysis. However, chronic elevated cortisol promote lipogenesis. Cortisol also has anti-inflammatory effect, which it can inhibit synthesis of arachidonic acid, which is precursor of inflammatory mediator, and causing downregulation of the immune response. Uh, Cortisol can reduce bone formation by reduce synthesis of type 1 collagen, reduce osteoblast production, and reduce intestinal calcium absorption. Cortisol provide maintenance for vascular responsiveness to catecholamine. It's upregulate alpha-1 adrenergic receptor in arterial to increase the receptor sensitivity and affinity, thus increase arterial vasoconstrictive. Next. So how does Cushing syndrome can occur? In Cushing syndrome, the HPA axis has lost its ability for self-regulation due to excessive secretion of either ACTH or cortisol and the loss of negative feedback function. Exogenous glucocorticoid as main causes of Cushing syndrome inhibit CRH and ACTH secretion caused bilateral adrenocortical atrophy. In Cushing disease is result from overproduction of ACTH by pituitary adenoma, which in turn result in adrenocortical hyperplasia and overproduction of cortisol. And it's also ACTH secretion is increased more than cortisol, and the receptor of ACTH is relatively decreased in Cushing disease. Next. The etiology of Cushing syndrome can be iatrogenic or the result of endogenous cortisol secretion in pituitary or adrenal pathology. Most common cause of Cushing syndrome is prolonged exogenous administration of glucocorticoid. And usually, this treatment is used in nephrotic syndrome, asthma, or severe bronchopulmonary dysplasia. For endogenous Cushing syndrome is rare and usually result from overproduction of glucocorticoid hormone, whether due to ACTH dependent or ACTH independent causes. Most common endogenous etiology in children older than 7 years old is Cushing disease, which is around 75% of all endogenous Cushing syndrome. And the typical etiology for children less than 6 years old or less or younger is adrenal pathology such as adenoma or carcinoma. Adrenal causes of endogenous occur approximately 20% in pediatric patient. Other than 3 causes that I mentioned above, the other condition is very rare to occur, approximately less than 1%. Next. During history taking, as chronic administration of exogenous glucocorticoid is the main causes of Cushing syndrome, we can ask the patient or the caregiver if they currently use the treatment, and any associated symptom that the patient or family member notice. The feature of Cushing syndrome is usually due to complication of corticosteroid therapy. Proximal muscle weakness occur due to catabolic glucocorticoid effect. We can ask the patient if they have any difficulty in climbing stair or getting up from the chair. Facial fullness is due to fat deposition, and ask the patient if they notice any skin changes such as bruising or striae. It is usually due to hypercortisolemia that cause skin thinning and loss of subcutaneous fat and connective tissue. Polyuria and polydipsia occur due to worsening hyperglycemia. Psychological problems such as depression and anxiety may occur in Cushing syndrome due to glucocorticoid metabolic effect on the glucocorticoid and mineralocorticoid receptor. Family history of Cushing syndrome is also important. Although majority of adenoma is sporadic, but a small number occur in family, especially in familial isolated pituitary adenoma syndrome, approximately 2% of pituitary adenoma. Next. The feature of Cushing syndrome appears more severe, and the clinical finding is more obvious in infant than in older children. In physical examination, the patient may show Cushing appearance. Obesity caused by excessive weight gain is due to increased visceral adiposity. Thus, the patient may have high BMI. Generalized obesity is common in younger children, and the severity is more in the face and trunk compared with the extremities. In Cushing syndrome, patient usually has short stature, usually below the third percentile. It is because corticosteroid is potent growth suppressor, and prolonged use in high dosage will lead to reduced adult height. And onset of obesity and cessation of growth may be the only early manifestation in pediatric patient with Cushing syndrome. Skin changes is due to hypercortisolemia that cause skin thinning and loss of subcutaneous fat. And striae is usually on the hip, abdomen, and thigh. It is common to occur in children older than 7 years old. Patient may also look depressed due to effect of cortisol to CNS. It is also common in patient with Cushing syndrome to have hypertension. Next. This is the feature of Cushing appearance. For the most right picture is acanthosis nigricans, is a dark discoloration of body fluid, body fat due to hyperinsulinemia, but it is not typical finding in pediatric patient with Cushing syndrome. Next. So if the Cushing syndrome is not diagnosed or treated early, it may lead to serious complication to the children. Osteopenia and osteoporosis can occur due to reduced bone formation. Myopathy result from catabolic glucocorticoid effect and can be worsened by presence of hypokalemia. Carbohydrate or glucose intolerance is due to stimulation of gluconeogenesis by cortisol and peripheral insulin resistance. A patient also has increased susceptibility to infection due to suppression of immune response by cortisol and may lead to sepsis if not treated. Hypercortisolism may suppress other pituitary hormone. Gonadal problem may occur due to action of glucocorticoid that inhibit gonadotropin releasing hormone, thus inhibit release of LH and FSH. But it is reversible after correction of the hypercortisolemia. Hypertension is more common in atopic ACTH syndrome than other form of Cushing syndrome. Hypertension also may lead to heart failure. Hyperglycemia may occur and may progress to frank diabetes or pre-diabetic condition. Metabolic alkalosis and hypokalemia occurs secondary to the mineralocorticoid activity of the cortisol. It is a common feature in atopic ACTH secretion, but may also occur in patient with Cushing disease. The unwanted side effect of systemic corticosteroid can be reduced by withdrawal of the treatment, but this need to be discussed further with the physician. So based on the information obtained in history taking and physical examination, we can make a differential diagnosis of the exact cause of patient with Cushing syndrome, thus lead to appropriate investigation. Next. The first step in diagnosis of Cushing syndrome is the detection of hypercortisolism. Typically, it can be done with midnight serum of or salivary cortisol, 24-hour urinary free cortisol or UFC, or by low dose of dexamethasone suppression test, DST. This test also used as a screening tool whether the patient have Cushing syndrome or not, but it cannot establish the causes, either it caused by ACTH independent or ACTH dependent. The diagnosis of Cushing syndrome is established when at least two different first-line tests are abnormal or showing Cushing syndrome, and physiologic hypercortisolism has been excluded. And once the diagnosis is established, additional evaluation is done to identify the cause of hypercortisolism. For midnight serum is a gold standard for detection of hypercortisolemia. Normal diurnal variation of cortisol is high in the morning and low at the midnight, but in Cushing syndrome, this circadian rhythm is lost. For midnight, salivary cortisol is useful in mild or cyclic Cushing syndrome, and sample can be collected at home, and it is also more convenient than midnight serum cortisol. For 24-hour urine-free cortisol, it provides direct and reliable practical index of cortisol secretion. It is recommended to have at least 3 consecutive collection. Cortisol excretion of more than 3 times the upper limit of normal can be diagnosed as Cushing syndrome. However, if the UFC is above normal but less than 3 times the upper limit, it may indicate pseudo Cushing syndrome, which is a condition that can mimic Cushing syndrome. Inadequate collection of urine may lead to low UFC level and may cause fast negative result. Next. In dexamethasone suppression test is done to assess normal physiology of the HPA axis. Dexamethasone is a synthetic glucocorticoid and more potent than glucocorticoid. The binding of dexamethasone to glucocorticoid receptor inhibit CRH and ACTH secretion. Since cortisol production is controlled by ACTH, decrease in ACTH lead to decrease in plasma and urine cortisol. There are two types of dose in DST, which are low dose and high dose. Low dose DST is used as a screening purpose to differentiate patients with endogenous Cushing syndrome of any cause from patients who do not have Cushing syndrome. High dose DST is to determine the cause of ACTH-dependent Cushing syndrome. There are two main protocols used in DST for both doses, the overnight screening test and 2-day test. In low dose, in overnight screening test, dexamethasone is taken orally at midnight, and blood sample is drawn at 8 a.m. the next morning for serum cortisol measurement. 2-day test is used to assess suppressibility in patients with equivocal overnight test or as an alternative to the overnight test. Dexamethasone is taken orally every 6 hours for 2 consecutive days and total of 8 doses. Blood is drawn 2 or 6 hours after the last dose for measurement of cortisol. In overnight high dose DST, the test is interpreted by calculating the suppression of morning serum cortisol concentration on the day before and the day after administration. Next. Most patients with Cushing disease have increase in ACTH and cortisol after the administration of corticotropin releasing hormone. Usually this test is combined with DST, but it did not improve the diagnostic accuracy in Cushing syndrome. Bilateral inferior petrocell blood sampling is the most direct way to demonstrate pituitary ACTH hypersecretion. This test is invasive procedure and performed if the biochemical workup is not definitive for a pituitary source or if a lesion is not visible on pituitary MRI. This test have greater accuracy if performed after CRH administration. For the other test is FBC, they may also increase total white blood cell, indicate infection, or GTT often abnormal but have no diagnostic utility. Level of serum electrolyte usually normal, but hypokalemia may occur especially in ectopic ACTH secreting tumor. Renin and aldosterone are low in adrenal lesion. Next. For imaging investigation, CT or MRI scan of the abdomen is used to identify adrenal tumor, and usually the lesion is unilateral. MRI of the pituitary may detect ACTH secreting pituitary adenoma, but usually it is too small to be seen, and the addition of gadolinium contrast can increase the sensitivity of detection. CT scan and also MRI scan of the neck, chest, pelvis may be required for detection of ectopic source of ACTH production. So after the diagnosis is established, it is necessary to determine whether it is caused by pituitary adenoma, ectopic tumor, for determining the appropriate therapeutic intervention. Next. So the image I provided is the left image is a CT scan in bilateral adrenal hyperplasia secondary to ACTH pituitary adenoma. The right image is MRI scan showing pituitary microadenoma. Next. So this is the algorithm in the determining the cause after the patient is diagnosed with Cushing syndrome. Either the patient have ACTH independent or ACTH dependent. Next. Management of Cushing syndrome is based on the etiology. Transsphenoidal pituitary resection is performed in pituitary tumor or pituitary adenoma. It is first-line therapeutic intervention in Cushing disease. Overall success is up to 60 to 80%, and low post-operative cortisol concentration may predict long-term remission. But if relapse occur, reoperation or pituitary irradiation may be required, and replacement with cortisol post-operatively is required until there is recovery of the HPA axis. Average time to recovery of the HPA axis in children usually 12 months. Early recovery HPA axis, which is less than 6 months, is associated with recurrence, and pituitary radiotherapy often used in adults but avoided in children due to complication of radiation, such as cerebral cortex toxicity and hypopituitarism. For adrenalectomy is done in adrenal tumor. Adrenalectomy rarely can improve the symptom, and bilateral total adrenalectomy is performed in bilateral nodular adrenal disease, and this procedure can lead to increased ACTH secretion by unresected pituitary adenoma that can cause marked hyperpigmentation or called Nelson syndrome. For management of undergoing adrenalectomy require intraoperative and postoperative replacement therapy with corticosteroid to avoid acute adrenal insufficiency. But in bilateral adrenalectomy, lifetime replacement with both glucocorticoid and mineralocorticoid is required. Laparoscopy and excision are required if ACTH is secreted by an ectopic tumor. Adrenal steroidogenesis inhibitor used preoperatively to normalize circulating cortisol level and reduce preoperative morbidity and mortality. Currently, there is no drug is approved by FDA in US in treatment of Cushing syndrome in pediatric patients. Cyproheptadine, pasireotide, and mifepristone are drugs used to treat Cushing syndrome in adults. And it is important to manage the patient post-operatively due to its complication, such as diabetes insipidus, syndrome of inappropriate antidiuretic hormone secretion. That's all from me. Thank you.
Okay, that's good. I don't like Cushing syndrome. I don't think this is relevant. We do have Cushing in pediatric, but most of them are actually secondary Cushing due to iatrogenic because of medication treatment. For example, what example of disease yang kita treat that develop Cushing that common in pediatric?
Asthma.
Asma ya ke? Asma dia dapat Cushing ke? Teruk sangat. No. We do treat asthma using steroid, tapi they don't get Cushing because of our inhaled steroid.
Sorry, Dato, what was the question?
Give me example of disease that end up having Cushing as complication of treatment.
Nephrotic syndrome.
Nephrotic syndrome is the most common kan. Nephrotic syndrome, SLE. What else? These are the most common lah, the most common condition yang on chronic steroid kan, chronic steroid medication. Okay, okay, ada soalan lain? Ada, okay, kalau tak ada, sambung lah next. You guys ada soalan ke? It's okay, nanti saya masukkan soalan ni untuk exam, don't worry. I akan masukkan di
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Aiman. I'm going to present about hypothyroidism and hyperthyroidism in pediatrics. This is my outline. For anatomy of thyroid, we've learned in year 1. Thyroid hormone is located in anterior neck, inferior to the larynx. It is a butterfly shape, which is bilobe, and then it's connected by the isthmus. And then for histology, we have follicular cells. This is follicular cells, which is to secrete T3 and T4. And then you've got colloid cells, extracellular storage of thyroid hormone, which contain thyroglobulin, which is important for the thyroid biosynthesis. And then for development, so thyroid is coming from outpouching of foregut, which is origin from endoderm at the base of tongue, call it as foramen cecum. And then after 7 weeks of gestation, migrates and descends as bilobe gland, and then at starting as early as 4 weeks of gestation, they start synthesis of thyroglobulin and then T4 and T3. In the second trimester of pregnancy, HPT, hypothalamic pituitary thyroid, start to mature. It is mature, but the normal feedback relationship are not mature until 1 to 3 months of postnatal life. And then it's a little bit about physiology of thyroid. Thyroid is to synthesis T4 and T3. And then these are the effects of thyroid hormone: effect to the bone, integumentary system, brain, heart, GIT, and liver. So basically, we know that thyroid is important for development and for in pediatrics, we're more concerned about the development. So hypothyroidism is a state of insufficient circulating thyroid hormone. I'm going to talk about congenital and acquired. So for congenital, these are the etiology of hypothyroidism. Primary congenital, it is caused by thyroid itself. So first one is thyroid dysgenesis, which is happen 80 to 90% of congenital cases. And then under thyroid dysgenesis, we got agenesis, which is no formation of thyroid, 30%, 33%, and then hypoplasia and ectopic, formation outside the outside from the normal place. And then this hormonogenesis, so this meaning that defect, hormone is hormone, genesis is production. So defects in hormone production, which occur 50% of the cases. So these are so basically this hormogenesis is the defect of enzyme production that is used to to synthesize T4 and T3, which is thyroid hormone. And secondary is a central, which is rare in infant, which is due to pituitary and hypothalamus. For acquired, there are a lot, but I choose these four. The first is autoimmune. The common one for acquired is chronic lymphocytic thyroiditis, which is Hashimoto disease, Hashimoto thyroiditis. And then second one is drug-induced due to excess in iodine. For example, drug amiodarone, which contain a lot of high concentration of iodine that can give Wolff-Chakoy effect. Wolff-Chakoy effect is something, the effect that when we give administration of too much iodine, and then it inhibit organification of iodine and thyroid hormone synthesis. Another drug is expectorant, so give Wolff-Chakoy effect. Then post-ablative is the treatment to treat malignancies and to correct the cardiac arrhythmia. So these are the example: therapeutic radiation, radioactive iodine, the secondary acquired due to hypothalamic pituitary disease, which most probably tumor. Let's go to congenital hypothyroid. The first, I'm going to differentiate between thyroid dysgenesis and dyshomogenesis. So for thyroid dysgenesis, it usually sporadic, so there is no increased risk in siblings, and the cause is unknown. But study have said that there's been reported it is from the familial, just 2 to 5% due to defects of transcription factors. And then for dyshomogenesis, it is an familial increase in family, which is autosomal recessive. So the risk is consanguinity marriage, which 30% of cases. And then it the causes are defects iodine transport. And then goiter almost always present. So to make you more clear about the dyshomogenesis, so this is what happened when this problem in NIS, sodium iodine symporter, is pendrin, and then TPO. So there is no production of T4 and T3 when all this enzyme is defect. So for congenital hypothyroidism, it is mostly asymptomatic, but the most common one that might present to you, that might present is patient cry little cry, sleep, somnolence, and sluggishness, appear slow and not alert. And then the next is poor appetite, which cause feeding due to feeding difficulties. Most probably because of macroglossia, which is enlargement of the tongue when for patient in hypothyroidism, and then it can happen in respiratory distress due to macroglossia, and then constipation. For the signs, we check for the vital sign. The temperature is below than normal, and the pulse is slow. When we look at the skin, it is cool, motile, and pallor, which is due to macrocytic anemia. And the skin of the patient might appear dry and scaly. And they also might be manifest as prolonged jaundice, which is yellowish discoloration. And we check for abdomen. This is standard with umbilical hernia. For the cardiovascular system, we look for the heart murmur, cardiomegaly, and pericardial effusion. For the head, the slightly increase in size due to myxedema. Myxedema is edema in the brain, which is occur in severe of hypothyroidism. it is said to be the cause of myxedema is when there is a aminoglycogen, and then it is bind to water, and then that's why it causes edema. And then we look for anterior and posterior fontanelle, which is we got two anterior and posterior. The pyramid shape are normally wide open. And then if the patient left untreated, there will be stunted growth, delay mental development, large fontanelles, and the eyes can be looked apart, and then a narrow palpebral fissure, and then swollen eyelid. You can see for nose, depressed bridge nose, and then for neck, short neck and thick. And then in between the neck and the shoulder, they might be present with fat deposit. And then we look for the hand, these broad and short fingers. And for the head, it is thickened scalps and coarse with scanty hair. And then this is the clinical manifestation depending on gene. For thyroid dysgenesis that I've said before, 2 to 5% may be due to this defect of the.
You can pause. You can skip this one.
All right. And then for acquired hypothyroidism, the most common one is Hashimoto thyroiditis. The risk factor is children with trisomy 21, Turner syndrome, and all these syndrome because they are associated with autoimmune polyglandular syndrome, which I will explain later about this. And then second one is familial cluster. Etiology is due to HLA associated with goiter and thyroiditis. And then another one is autoantibodies of the thyroid antigen. So there will be a complement cascade activation, and then that cause autoimmune. And then this is the clinical manifestation. So for thyroiditis, most common one is goiter and slow growing. So patient might come to you complain about goiter, and the children is slow growing, and then patient are clinically euthyroid and asymptomatic. And there's also sign and symptom of hypothyroidism. And then if it is severe, there will be thyrotoxicosis, which is appear to be tremors and then increased sweating. So for APS, autoimmune polyglandular syndrome, is said to be one of the factors that can cause the autoimmune. So type 1 is less common, the type 2 is more common, which is 70%. So this APS associated with type 2 associated with type 1 diabetes mellitus, Addison disease, and pernicious anemia. For type 1, it is rare, and then it is said to be mutation of IRE, which is one of the gene due to autosomal recessive. So this is more detail about the presentation and the signs, so you can read later. So basically, it is the effect when all this when there's no thyroid. So what happened to all this systemic and systemic presentation to that patient. Next is hyperthyroidism, the synthesis and secretion of excess thyroid hormone from thyroid gland. So it is different between thyrotoxicosis, where thyrotoxicosis it is excess of thyroid hormone, but regardless of where it's coming from. So for Graves' disease, it is rare in children, but normally peak incidence is 11 to 15 years old, and patient got family history of autoimmune, more prone to get Graves' disease, and then associated with HLA-D3 related disorder, such as Addison disease and diabetes type 1. So the pathophysiology for Graves' disease, when there is high activated B lymphocyte, which is maybe due to all these factors in thyroid, and then another one is a failure of T suppressor cells, which allow expression of T helper cell to sensitize TSH antigen. And then there will be interaction antigen to B cells. So B cell produce TRS, which is thyroid stimulating antibodies, and then bind to its receptor. Antibody bind to the receptor will stimulate production of CAMP, which resulting in thyroid hyperplasia. So the patient might present to you with goiter and exophthalmos. Exophthalmos is the eye protrude, the eye appear large, protruding out, and then, or maybe you can see there is a retraction of the upper eyelid. This is the detail about the clinical manifestation. So consensual symptom, weight loss. It is in contrast to what in hypothyroidism. Yeah, so patient might have increased appetite, but they still have weight loss. For investigation, we do thyroid function tests. The first one is thyroid stimulating hormone, which is we can distinguish between hyper and hypothyroidism. In hypothyroidism, the TSH will be high, but T3 and T4 may be normal. But in subclinical hypothyroidism, TSH will be high, but T3 and T4 may be normal. It is normal. Another one is total T3 and T4 to differentiate between the subclinicals and hypothyroidism. And then we measure free T3 and T4 to confirm the diagnosis. And the additional test is to look for immunoglobulin, which is thyroid stimulating immunoglobulin, thyroglobulin antibody, and TPO. So thyroglobulin antibody is normally associated with autoimmune thyroiditis in 33 to 55%. And then TPO, normally when there is high in TPO, we consider the patient got Hashimoto thyroiditis, which is 95% of the cases. So this is the treatment we given to the patient. For hypothyroidism, we give levothyroxine. So this picture show after the treatment, we can see there's no reduce in swelling, and then the eye, the nose is getting better. There's no breach. And then for hyperthyroidism, you give antithyroid, for example, metimazole. So in congenital, we do give this levothyroxine, and then we monitor the progression of the fetal development, and also if the patient got severe hypothyroidism, we give high dose. That's all from me for hypo and hypothyroidism. Is there any question?
Okay, good. Any questions?
I have a question. Can you explain again about what does it mean by thyrotoxicosis?
Oh. Thyrotoxicosis, the difference between so the patient with hyperthyroidism might have thyrotoxicosis. Thyrotoxicosis is excess circulating thyroid hormone, and it has the clinical manifestation, but regardless from what it's coming from. So, but in hyperthyroid, it is coming from the high amount of hormone is coming from thyroid. But in thyrotoxicosis, it might get from the thyroid, and also it might get from other sources. Is that clear?
Thyrotoxicosis is a high amount of circulating thyroid. Right.
Yes.
But how in the hypothyroidism there is also thyrotoxicosis?
Um, in that case, I think from what I've read, it says that due to destruction. I'm sorry. I think due to destruction of the thyroid. I forgot about that. Can I explain to you later?
Good.
Yeah, sure. Thank you.
Okay, any other questions? Remember, hypothyroid, especially congenital hypothyroid, is the most common endocrine problem lah in children. So you need to know in and out congenital hypothyroid. Otherwise the rest is okay. Okay. Next.
Doctor, I have a question on on the treatment for congenital hypothyroid. For patient that got thyroid dysgenesis or agenesis, which is no thyroid hormone, what happened for the long term?
Dysgenesis can be transient or can be permanent. Okay. Because dysgenesis can be because of immaturity of the thyroid gland. So, and this is the most common cause lah. But I think about more than 90% of congenital hypothyroid is because of thyroid dysgenesis. Because of immature thyroid gland.
So
they've got not enough. But you have to remember, I think you had mentioned tadi kan, function of thyroid hormone. Okay. The most important function of thyroid hormone is actually brain development. And brain, they completely develop by the age of 3. Before that, we call the period is thyroid dependent brain development macam tu lah, I can remember lah. Tapi thyroid dependent. So brain will depends a lot on thyroid hormone before the 3 years of life. Okay, the first 3 years of life, brain will depend on thyroid hormone to develop. So if a child got hypothyroid during the first 3 months of life, 3 years of life, they will become retarded lah. Dia kan buat cretinism semua tu lah, retarded. Okay. So the first 3 years of life, you will need to supplement. Anyone suspected or confirmed hypothyroid, you need to supplement them for the first 3 years of life. After 3 years, once if you see the requirement is very low and there's a high chance that the patient able to produce enough thyroid hormone, then you can actually try to stop the thyroid supplement and do ultrasound. ultrasound or MRI lah, the gold standard is MRI, to look for the presence of thyroid hormone, normal size thyroid hormone, thyroid gland, sorry. So if there's presence of thyroid gland and patient remain euthyroid without the thyroid hormone, then you can stop thyroid hormone for good. Tapi kalau, but you don't try this, you won't try this before 3 years old. That's a general principle lah. But nowadays the management is changing. We do tend to stop thyroid supplement earlier. Because we know 90% of those with congenital hypothyroid are actually transient.
Oh.
Okay, so tapi kalau this is agenesis, memang usually the child by 3 years old, the requirement will increase. They will need high dose and they will remain on thyroid forever lah. Okay.
Okay. Thank you, Doctor.
Okay, next.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Sofia binti Ruslan and I'll be presenting about rickets. So this is the outline for today's presentation, starting from the definition to the managements. So what is actually rickets? So rickets is a failure in mineralization of the growing bone or osteoid tissue. So this condition also can occur in the osteomalacia, but the differences is osteomalacia, it's occur in the mature bone. And then the epidemiology of rickets. So previously in 1930s and 1920s, the prevalence of rickets in the Europe and USA is very high. It's around 75%. But the nutritional rickets practically disappeared from the industrialized country when the vitamin D food fortification program started. So mostly it occur in the breastfed infants who have dark skin and receive no vitamin D supplementation. For in Africa, mainly because of a nutritional deficiency, like calcium and phosphorus. For Middle East, mainly in the infant bundle in the clothing and are not exposed to the sunlight. So there's re-emergence in different countries in the past 10 to 20 years because of combination of factors. The first one is less sun exposure. So when less sun exposure, it means that less exposed to the UV radiation. So UV radiation is very important in the vitamin D synthesis. And when there is decrease in vitamin D, it will lead to the ricket formation. For example, the use of sunscreen lotion, skin coverage, less time spent outdoors, as well as the darker skin living in the temperate climates. This is because darker skin, you have a more pigment melanin, and this one will absorb the UV radiation, leading to decrease in the vitamin D synthesis. So what about in Malaysia? So as we already know that vitamin D deficiency will lead to rickets, there's a lot of study done to see the prevalence of vitamin D deficiency. So there's one study on adolescent aged 13 years old. The prevalence of vitamin D deficiency is as high as 78.8%. And also there's also one study done in 2008 among primary school children. The vitamin D deficiency prevalence is at 35.3%. And another study also done in 2013 and revealed almost half of the children had vitamin D insufficiency, and the prevalence of the vitamin D deficiency mainly higher among Indian and Malay ethnicity because of greater pigmentation. So this is the risk factors for having rickets. So the first one is dark skin, lack of exposure to the sunlight, especially because currently right now PKP, mainly people indoor living. And then also mother's vitamin D deficiency during pregnancy, when there is prolonged breastfeeding without appropriate complementary feeding for 6 months. And also when there is premature birth, because throughout pregnancy, phosphorus and calcium is being transmitted from the mother to the fetus. But the most prominent is occurring during the 3rd trimester. So when there is a defect in the process, that's why they can have low calcium as well as low phosphate. And then the medication like anticonvulsant can increase the catabolism of vitamin D, and also when there is low vitamin D as well as calcium diet. So next is to understand the rickets pathophysiology, you need to know the vitamin D metabolism. So cutaneous synthesis of vitamin D is the main source of the vitamin D. So it started from the skin, which is the pro-D3, which is 7-dehydrocholesterol, converted to pre-D3 by the UVB, and then converted to the vitamin D3 cholecalciferol by the presence of the heat. And diet or supplements can also supply the vitamin D3 as well as vitamin D2, and this will bind to the vitamin D binding protein and go to the liver, and then it will undergo hydroxylation by the enzyme 25-hydroxylase, which will be converted to the calcidiol, which is 25-hydroxycholecalciferol. And then in the kidney, it will undergo another hydroxylation by the presence of 1-alpha-hydroxylase. So it will convert it to 125-dihydroxy vitamin D, which is known as calcitriol. So what is the effects of the calcitriol? It's in the intestine, it will increase the calcium and phosphorus absorption. In bone, it increases the calcium and phosphorus mobilization. In the kidney, it increases the calcium and phosphorus absorption, while in the parathyroid gland, it decreases the parathyroid hormone synthesis and also secretion. So this is the types of rickets. We have calcipanic rickets as well as the phosphopanic rickets. So calcipanic means because of lack of calcium. So the first one is the vitamin D deficiency rickets, which is the causes include nutritional ricket, which means lack of diet of the calcium as well as vitamin D. Second is lack of sunlight. Third is secondary to the malabsorption syndrome like inflammatory bowel disease as well as celiac disease. Second is increased vitamin D catabolism like the usage of the anticonvulsant drugs. The third one is when there is 25-hydroxylase deficiency. So 25-hydroxylase located in the liver. So it can occur when there is severe liver disease and also when there is vitamin D dependent rickets type 1B. So this one is when there is mutation in the gene encoding the 25-hydroxylase enzyme. And then next will be 1-alpha-hydroxylase deficiency. So this one is located in the kidney. So it can occur when there is chronic kidney disease as well as when there is vitamin D dependent ricket type 1A. So this one is when there is mutation in gene encoding the 1-alpha-hydroxylase. And the last one is the end organ resistant to 125-dihydroxy vitamin D, which is the causes is the vitamin D dependent rickets type 2. This one is when there is mutation in the gene encoding the vitamin D receptor. So it causes a defective in the normal physiological response to the 125-dihydroxy vitamin D. Next is the phosphopanic rickets. So the first one is nutritional phosphate deprivation. Can occur because of prematurity as well as on diet, which is locate brain formula. The second one is the renal tubular disorder, which is Fanconi syndrome. This one, when there is defect in the proximal tubule, which leads to the renal wasting of the phosphate amino acid. And then for tumor, we have tumor-induced osteomalacia, as well as genetic mutation like X-linked hypophosphatemia, autosomal dominant hypophosphatemic rickets, autosomal recessive hypophosphatemic rickets. For this, it will lead to, they will release a factor, which is the FGF23 factor. So this factor will lead to the decreased reabsorption of the phosphate, as well as it will inhibit the 1-alpha-hydroxylase. And then the last one is the hereditary hypophosphatemic rickets with the hypercalciuria. This one is when there is mutation in the sodium phosphate transporter, which will lead to the wasting of the phosphate. So next is the pathophysiology. So mainly I'll be explaining about the vitamin D deficiency. So when there is vitamin D deficiency, it will lead to decrease in the calcium and phosphorus absorption from the intestine, leading to decreased serum calcium level, which will stimulate the parathyroid gland to release the parathyroid hormone in order to normalize the calcium level. So it will stimulate the 1-alpha-hydroxylase enzyme to increase activity, to increase the synthesis of 125-dihydroxycholecalciferol, which indirectly increase in calcium absorption in the gut. Second is increase the mobilization of the calcium and phosphorus from the bone. And the last one is increase the calcium reabsorption and decrease the phosphorus reabsorption in the kidney. That's why it will cause decrease in the serum phosphorus. And if this condition persists, hypocalcemia may be evident again, which will lead to the failure in mineralization of the osteotissue and cartilaginous matrix, leading to growth plate disorganization and accumulation of undermineralized osteoid, and results in the growth plate expansion, bone weakening, and skeletal deformities, which is the manifestation of the rickets. So this is the clinical features that you can find in the rickets patient. For general, the patient can be a listlessness, that can have growth failure, muscle weakness, as well as fracture. For head, you can expect there is craniotapes. So this one is the softening of the skull bone. So you can detect when you apply a pressure, and then the sensation is similar to when you press a ping pong ball and you release it. And second, we have frontal bossing, which is the prominent forehead, and then delayed fontanelle closure. Usually it will be closed by 2 years old. And then delayed dentition, usually which is when no incisors by age of 10 months and no molars by age of 18 months. Okay, next, for back, you can expect scoliosis, kyphosis, as well as lordosis. For chest, you can have pectus carinatum, which is pigeon chest. Second is Harrison sulcus, which is the horizontal depression at the lower chest, which mainly because of attachment of the softened ribs to the diaphragm. And then we have rachitic rosary, which is the widening of the costochondral junction. And then the last one is the respiratory infection and atelectasis. This is mainly in the vitamin D deficiency, because when there is vitamin D not only involved in the calcium as well as the vitamin D metabolism, it also important for the immune system as it enhances the innate immunity by express and release the antimicrobial peptide. So next, for skeletal, you can expect widening of the ankles and the wrists, mainly because of the widening of the growth plate, and also they can have bowing of the arm and bowing of the legs, mainly because of the weight bearing, like when crawling as well as when walking. So the term genu means knee. Varum means bend outward. So you can see it bend outward. And then knock knee, which is genu valgum. Valgum means bend inward. Okay. And then you can also expect some hypocalcemic symptoms, including the seizure, tetany, stridor caused by the laryngeal spasm. So to diagnose the rickets, it's based on the presence of classic radiographic abnormalities. So it is supported by the history, physical examination findings, as well as the laboratory results. So for history, you need to ask about the nutritional history, like vitamin D and calcium intake, as well as you need to ask for dietary fibers, because when a lot of intake of dietary fibers, it will impair the absorption of calcium. And the third is exclusive and prolonged breastfeeding, as well as the composition of the formula or the milk, because for example, if the mother gave soy milk is deficient, it doesn't contain enough vitamin D as well as minerals. And next is exposure to the UV light, like the time spent outside, the sunscreen use, the clothing, and also the maternal risk factor, like lack of supply of vitamin D in diet, sunlight exposure, medication like anticonvulsant, as well as the phosphate binders or aluminum containing antacid, because this one impair the absorption of the phosphate. And then medical history, like history of liver or intestinal disease, which can cause the malabsorption of vitamin D, the fat malabsorption, as well as the history of renal disease. You will also need to ask about the family history of rickets, because there's a lot of the etiology that come from the genetic causes. For physical examination, mainly you want to look for the manifestation of the rickets, general examination, and you also look for the guide, because they can have waddling guide, and also you need to plot the growth chart. And for respiratory examination, look for the chest manifestation, as well as you need to auscultate the lung in case for atelectasis. And then the last one is musculoskeletal examination. Look for any bony tenderness as well as bony abnormalities. For investigation, this one is mainly for vitamin D deficiency. So this parameter include, first is serum 25 hydroxy vitamin D. It usually will be low, and this is a useful indicator for vitamin D status of the patient. For serum calcium, it can be low or normalized by hyperparathyroid. And if the patient having severe hypocalcemia, the patient can have a seizure, tetanic spasm, as well as hypocalcemic cardiomyopathy. And next is serum phosphate. It usually will be low, and this one is the one who responsible for the growth plate defects. And then serum parathyroid usually will be elevated. Usually elevated in calcipanic, but usually normal in the phosphopanic rickets. And the last one is serum alkaline phosphatase. Usually will be elevated in both either calcipanic or phosphopanic rickets. So this one is the marker of bone turnover, but this is not specific to the bone, as it also released by the kidney, by the liver. But in children, most ALP is produced in the bone, and it shows significant association with the severity of the condition. So this table shows the detailed biochemical findings differentiated between the etiologies. So you can read this later. So, and then moving on to the second part, which is the imaging. So you can expect cupping and fraying of the metaphysis. So for fraying means the metaphyseal edge that lose its sharp border like this. So, and then cupping means transformation of the edge of metaphysis from the convex or flat to the concave surface like this. And then also you can expect widening of the growth plate. And then also bowing of the legs as well as the rachitic rosary, which means the bulbous enlargement of the costochondral junction. So for management of patient, first is for vitamin D deficiency. So you can give either ergocalciferol or cholecalciferol through STOS therapy or daily therapy. STOS means you give high dose of vitamin D in one day, like 300,000 to 600,000 international unit per day, 2 to 4 doses. And daily therapy, you give around 5,000 to 10,000 international unit per day, daily for 2 to 3 months. So ideal strategy should be followed by the 400 international unit per day in the diet. So of course, you need to monitor biochemically and also radiological and monitor for excess chronic vitamin D symptoms like the hypercalcemia, muscle weakness, polyuria, and also nephrocalcinosis. And then others, you need to ensure the patient having adequate dietary calcium as well as phosphorus intake. But if the patient having hypocalcemia, you can give IV calcium acutely followed by the oral calcium supplement. And then for orthopedic intervention, it may be necessary if deformities do not eventually improve after medical therapy. So prevention, ensure adequate exposure to the sunlight, adequate dietary intake, as well as you can have a supplementation with the vitamin D, usually 400 international unit of vitamin D in infant and 600 international unit per day for older children with the risk factor for inadequate intake. So this is briefly the management summary and flowchart for vitamin D deficiency. The thing that I want to point out is, first, when you want to deliver the vitamin D, you need to know the age of the patient, look if the patient having manifestation, as well as look the serum 25-hydroxy vitamin D to look if the patient is having sufficiency, insufficiency, or deficiency, because the dosage is different between the condition. And then the last one is the genetic causes. So genetic condition resulting in rickets are best treated by pediatric endocrinologists and or metabolic bone specialists. So the first one, when there is vitamin D dependent rickets type 1A or B. So this one is when there is a problem in the enzyme. You have deficiency in enzyme like 25-hydroxylase and 1-alpha-hydroxylase. So you need to give active vitamin D because they cannot activate the vitamin D. So you give calcitriol. And then for vitamin, just add on, like also when there is the chronic kidney disease, you also need to give activated vitamin D. And then for vitamin D dependent ricket type 2, usually we give high dose calcitriol and also calcium. So and for those who does not respond, we'll give a long-term IV calcium and possible transition to very high dose oral calcium supplement. And the last one for familial hypophosphatemic rickets, so we give oral phosphate supplementation along with the vitamin D as calcitriol or alpha-calcidol. So alpha-calcidol is the pro-hormone for the calcitriol. So this one will go to the liver and will undergo hydroxylation by the 25-hydroxylase, and then it will directly activated become 125-hydroxy cholecalciferol, which is the calcitriol. Okay, that's all. This is my reference. Thank you.
Okay, any questions? Okay lah. Any questions? Rickets is very important. There's a lot of causes of rickets, but most of the time it's caused by nutritional. It's hypovitaminosis D, vitamin D deficient, mainly due to nutrition. So I think the most important slides that you presented is the slide, the earliest slides. And you show the history, the physical examination, the history lah. That's the most important slides. Okay, because most of the time you can get the causes just by history. Yes, this is very important slides. And then what else? And usually familial rickets are caused by hypophosphatemic rickets, either vitamin D dependent or vitamin D independent. And if I'm not mistaken, these two are actually X-linked recessive. So it's more prone to male lah. Otherwise, any other questions? Okay, tak ada eh? Okay. If nothing, then I think that's all lah kot. Ada presentation tak? Tak ada kan? You ada last right? Okay lah, so I think that's all. Okay lah, can you give me your slides? Then I can give you a mark. The mark for your slides. The presentation, okay lah, I can give you a mark for presentation, but for the slide, I need to really look at your slides because there's too many, a lot of information. Okay lah, I think that's all. Thank you. Speaker for this webinar.
Thank you very much, Doctor.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thanks, Doctor.